Start then.
Yes, sir, we can start.
Okay. Right. So today is the last session in respiratory medicine, and we'll be focusing on pleural disease, pulmonary vascular disease, and bronchial carcinoma as the last few things. But before that, I just want to give you an additional MCQ on TB. මම හිතන්නේ කලින් එකේ තිබුණාද? I can't remember, but there is a MCQ on TB in this. Was this the annual MCQ paper? Can't remember, sorry.
No, sir.
No, neither. Come on, let's do this. Because I sort of missed something out somewhere, MCQ. Okay. Right, so last week we were talking about tuberculosis, and this is another MCQ on TB. Right, so this question is focusing on post-primary or secondary tuberculosis. Now, it's very important to understand that sometimes patients with a history of TB, right, they present with hemoptysis. And for some groups at least, I have discussed this scenario as a long case as well. When this happens, there are two things that you need to think of. One is that, could this be a reactivation of tuberculosis? That's the first thing you think of. Second thing is, in patients who have had TB in the past, within the cavities, they can develop fungal infections or fungal balls, right? These are aspergillomas. So another cause of hemoptysis in a post-TB patient would be aspergilloma. Of course, there might be other explanations for the hemoptysis that you need to look into, like bronchial carcinoma and so on, but these are important things. Right. Then the next MCQ is in post-primary TB, amphoric breath sounds are audible. So amphoric breath sounds, that's a particular type of bronchial breathing that you hear over a cavity. And yes, in TB, especially secondary TB, cavitation is very common. And therefore, you might be able to hear amphoric breath sounds, which is a feature of a cavity, clinical feature or clinical sign that you get in a cavity. Another similar, there are some other important physical signs over a cavity which you might like to note down. One of them is called post-tussive suction, right? So when you ask the patient to cough, right, and then suddenly when they breathe in, they get a sort of popping sound, right, over the cavity. That's called post-tussive suction, right? When they cough out, the cavity sort of collapses, and then it then rapidly fills up, causing a sort of a popping sound, right? That's called post-tussive suction. Those are two important physical signs of a cavity. There's another one called the crackpot sign, which is not very important to know. Right, so these are some features that you get over a cavity. Post-primary TB causes elevated vitamin D levels, right? Now, actually, එක හදාගන්න calcium levels කියලා. Sorry, එක calcium levels කියලා හදාගන්න. So it can cause hypercalcemia. So post-primary TB can cause hypercalcemia because the granuloma can secrete vitamin D-like substances, right? Granuloma. We see this phenomenon in sarcoidosis also. The granuloma can secrete vitamin D-like molecules, which can cause hypercalcemia. So what I wanted to ask was elevated calcium causes hypercalcemia. The same phenomenon we see in another granulomatous disease called sarcoidosis. Right. TB meningitis is the most common extrapulmonary manifestation is wrong. It's a sort of a close tie between lymph node TB and pleural TB, right? Extrapulmonary manifestations. Remember, pleural TB is an extrapulmonary manifestation. And lymph node TB are the sort of leading extrapulmonary manifestations. Now, lots of respiratory disorders present with SIADH, as you know, and that can be the explanation for hyponatremia in TB as well. So TB, post-primary TB, they can get hyponatremia due to SIADH. Right, so MCQ that I've sort of dropped off your paper, but important things to remember for the exam. Hari, any questions about that one? Okay, right. So let's go. Right. So all of you have seen very similar chest X-rays where the patient has a homogeneous opacification of a hemithorax, right, with a meniscal upper border, right. So there is a meniscal upper border and a homogeneous opacification of the hemithorax, and this is characteristic of a pleural effusion, right. It's characteristic of a pleural effusion. Now, this I have discussed several times during your appointment for most of the groups, right? And pleural effusions etiologically can be divided into exudative pleural effusions and transudative pleural effusions. Exudative pleural effusions, we use Light's criteria as a means of diagnosis. Of course, if the pleural fluid protein is extremely high, you can diagnose it on the pleural fluid protein itself, right? But this is always a nice way to sort of see whether it is actually an exudate, right? So I have listed Light's criteria there, and there's another one called modified Light's criteria, which is on the right side. Modified Light's criteria, right? But the traditional Light's criteria takes a ratio of the pleural fluid protein and serum protein, the pleural fluid LDH and the serum LDH, and also quantifies the pleural fluid LDH compared to the upper limit of the serum LDH, right? So this is your Light's criteria. Now, in the next slide, I have given you, this is a very important slide for MCQs. Unfortunately, again, because we ask true-false MCQs, you can get an MCQ, okay, what of the following are exudative pleural effusions, right? So here in this table, you have a nice list of transudative pleural effusions and exudative pleural effusions, right? That is important. Remember that there are some unusual things that we like to ask you, right? Which might appear in these lists, right? Now, especially something like Meigs syndrome, which is associated with ovarian tumors, right, cause a transudative effusion, right? Slightly special thing, right? Pulmonary embolism related pleural effusions, some of them are exudates, some of them are transudates, right? So there are a few sort of tricky things in these lists that you need to be aware of that can go either way. Especially the pulmonary embolism, majority are exudates, but you can have transudates in about 20% of all related effusions, right? But the other ones you can generally work out. Malignancies, infections, all of these things are exudates, right? Whereas effusions related to heart failure, nephrotic syndrome, these are all transudates. But there are a few tricky ones which I have highlighted. And I hope that you'll be able to answer this question without a problem. Right. Any questions up to now?
So what is urinothorax?
Urinothorax is the accumulation of urine in the thorax, right? That's a very rare condition that can happen. I've seen it once, right? Okay. Right. Now, question number 2 again is a sort of a data MCQ එකක්. What are the causes of a blood-stained pleural effusion? Right. So this will give you sort of an idea of causes of hemorrhagic pleural effusions. Right. Causes of hemorrhagic pleural effusions. And these are some of the lists that you need to remember when you do your MCQs. Unfortunately, most of the time, hemorrhagic pleural effusion will indicate some sort of malignancy, most of the time. But there are some uncommon causes of hemorrhagic pleural effusions, as you can see, like pulmonary embolism, like post-MI pleural effusions, right? Pancreatitis. These can sometimes give rise to hemorrhagic pleural effusions. Right. Okay. Right. Now, question number 3 is again, we're asking some of the clinical manifestations of pleural effusion and also certain investigation findings. Right. Bronchial breathing may be detected along the upper border of the pleural effusion is something that I told you during your appointment. So we gave the classical features of pleural effusion, which are reduced chest movements on the affected site, right? Then the breath sounds are absent or significantly diminished. The stony dull percussion was very important. And I told you that you might be able to hear a rim of bronchial breathing on the top of the pleural effusion, over the upper border of the pleural effusion. I told you that in massive pleural effusions, the trachea may also be deviated to the opposite side because of the push on the mediastinum. But I also told you during your some of the short case classes that we did, that sometimes when the pleural effusion is so big, right, the underlying lung can collapse, right? So the net effect of the pleural effusion pushing the mediastinum and the collapsed lung, which is now pulling the mediastinum. So the net effect might be that the mediastinum is in the midline or remains in the midline. I told you that this is an important question. Hariyata api ahana oka viva wala hema nittarama ahana prashnayak in the short case, right? So whereas the net effect of the pleural effusion, which is pushing the mediastinum, and there is a collapsed lung which is pulling the mediastinum, this net effect might indicate that the thing is finally in the midline, right? So these are some important physical signs related to pleural effusions. Hari. Okay. Now, the next few things are about investigations. Now, the investigation of choice to diagnose a pleural effusion is chest X-ray. That is obviously the easiest, accessible, most accessible investigation. But remember, in the chest X-ray, you cannot detect small pleural effusion. For example, 50 ml vage tiyenewa, you can't detect on a chest X-ray. From my experience, you need at least about 200 ml of fluid to detect a pleural effusion. Definitely not 50. You can't detect it. Ultrasound, you might be able to detect a 50-100 ml pleural effusion. Ultrasound, right? So chest X-ray ke 50 විතර ඒවා detect කරන්න බැහැ. Ultrasound, you might catch it. Ultrasound, you can use for these small effusions. Ultrasound is useful. But still, we use X-rays most of the time as the standard test. Right. Now, on Thursday, we talked about pleural infection or empyema. And there I told you that in pleural empyema, there are certain characteristics. So they will have ongoing features of infection. That scenario, the patient had pneumonia and then recurrence of fever, hemoptysis wage features occur. And the patient was getting sick. So then we discussed that, okay, what are the features of an empyema? So ongoing features of infection. And if you were to aspirate the pleural fluid, it's obviously an exudate, but there might be frank pus coming out, right? Also, the Gram stain would be positive because there's direct bacterial invasion into the pleura. Bacteria කඩාගෙන යනවා pleura එක ඇතුළට. There is direct bacterial infection of the pleura, right? And so Gram stain would be positive. And I also told you that because the bacteria there are using the glucose in the pleural fluid, the glucose level would be less than 60 milligrams per deciliter. And also the pH would go down because remember the bacteria are producing lactic acid inside the pleural cavity. They are metabolizing stuff within the pleural cavity. So pH should be less than 7.2. So I told you if there is a suspicion of an empyema, you have to aspirate it, do all these tests, and the treatment is to put an IC tube in. I also told you that on ultrasound scan, patients with empyemas have septated, encysted effusions, right? And you can't say that they do not require aspirate. You need to aspirate them to check for empyemas, right? And drainage, if that doesn't work, Thursday, if drainage does not work, we need to go in and break the adhesions and septations to drain it out. Otherwise, the patient will never get better. Right. So that is that. The third statement එක ගැන තමයි ඔය කියන්නේ. Pleural effusion with a low pleural fluid glucose occurs in empyema, right? Also occurs in rheumatoid arthritis. I have also given you a list of other causes of low glucose pleural effusions like TB, malignancy, right? කල මේ list එකෙත් pH less than 7.2 වලට causes වගේකුත් I have given, right? So Cyruban to detect clinically pleural effusion at least 300 to 500 ml වත් තියෙන්න ඕනේ. Right. Right. Now some people present with recurrent pleural effusions, right? In that case, we do pleurodesis as a management option. But remember, pleural effusion, you have to find the cause, right? But sometimes these are so recurrent that you might need to therapeutically obliterate the pleural cavity, and this is called pleurodesis. Pleurodesis. Antima එක හරි. Right. And this is what a sort of septated encysted pleural effusion looks like, right? You can see the pockets of fluid, the septations, all of that there, right? On the CT scan again, you can see these very thick wall septations and the fluid in between. So these are sort of complex pleural effusions that you get in empymas. And we try IC tube drainage. If that does not work, you need to go in surgically and remove the septations. Right. Okay. Any questions about pleural effusions? Tisura.
So do we tap all pleural effusions to diagnose, or some can we watch and wait?
No. So it depends on your clinical suspicion. Now, for example, if you have a patient with heart failure who has a pleural effusion, you are not going to tap that, right? So it all depends on your clinical suspicion of the cause. I would say that if there is a suspicion that it's an exudate, you do often tap it, right? Say if you're suspecting malignancy or tuberculosis or something, when it's a sort of exudative effusion. But when there's a clear cause like heart failure, right, or renal failure, you're not going to tap the effusion. There is no point unless, of course, you suspect some infection on it. Yeah. So we do tap a lot of pleural effusions, but we don't, if the cause is clear like heart failure, there is no point. Yes, Navin, you can do a lateral decubitus, but that's not very often done nowadays, right? Smaller pleural effusions, you can detect the lateral decubitus, but they are very karane. Pediatrics or none karno samahara. Malignant pleural effusion, of course, depends on what type of malignancy it is, and the treatment is very complex. Depending on the type of malignancy, there are various things that you will do. Right. Right. So this one X-ray again, very clear that there is a pneumothorax on the left side, neither, and you can see the edge of the collapsed lung as well. Right. So if the effusion is massive, yes, you sometimes drain for symptomatic benefit. Yes. Yes, that is done sometimes. The patient is extremely symptomatic. Yes. Right. Okay. Now the next question, obviously you guessed it, is on pneumothorax. Yes. So pneumothorax, you have primary spontaneous pneumothorax and secondary pneumothorax. Right. So secondary pneumothorax occurs in patients who have structural lung disease, right, or who are smokers, right? So smokers, people with structural lung disease, they tend to get secondary pneumothoraces. Primary spontaneous pneumothoraces are commoner in males, tall males. That is the group that you see. Tall males is where you see the spontaneous, primary spontaneous pneumothorax. right? Now here, I have given you causes of secondary pneumothorax, right? So, of course, all of you will be familiar of sort of things like COPD or asthma causing pneumothorax. And that's very important to talk about because it's important to do a chest X-ray in patients who have asthma or COPD when they are not improving. And the whole point of doing that chest X-ray is to look for a secondary pneumothorax. But also remember there are other causes of pneumothorax, secondary causes. Connective tissue disease can give rise to pneumothorax. Also, cavitating lung infections, right? So infections that cause lung cavities, these cavities can burst open and cause pneumothorax, right? And TB is a good example, really. Pneumocystis carinii or neurocystis gyroversi can also cause sort of cystic cavities in the lungs. And these can rupture, causing a pneumothorax. Some connective tissue, interstitial lung disease causes pneumothorax, and I have given you a list there, right? And again, things like lung cancer sometimes can infiltrate into the pleura and sort of break open the pleura, causing a pneumothorax. So these are rare, very rare. So these are the main causes of pneumothorax. So this is how you classify your causes of pneumothorax into primary, spontaneous, and secondary. Secondary, you need to remember some of these common and uncommon causes for the exam. Right. So primary spontaneous pneumothorax, males lage thamai වැඩි. Pneumothorax is a recognized complication of pneumocystis infection. That is also correct. Now, typically we diagnose pneumothorax on chest X-ray, but recently we know that it can be diagnosed on a ultrasound scan as well. And you get something called a barcode sign on ultrasound scan. Of course, you have to be trained to do lung ultrasound scan. It's not very easy, but you can detect it if you are careful, right? A barcode sign on the lung pneumothorax. Right. Now, the next questions are based on this algorithm that you need to know, right? This algorithm. So this outlines the management of a pneumothorax. This is, remember, non-traumatic. Right. So if there is a spontaneous pneumothorax and the patient is hemodynamically unstable, you have to immediately put in an IC tube, right? You might relieve the pressure with a needle sort of in the second intercostal space mid-clavicular line, but the patient will definitely need the IC tube immediately, right? Because if it's hemodynamically unstable, that suggests a tension pneumothorax. Right. If you have time to play around and the patient is stable, the next thing to do is you have to say, is this likely to be a primary pneumothorax, or is it likely to be a secondary pneumothorax? The fact that the patient is more than 50 with a significant smoking history, right? Or there is evidence of lung disease or history of other lung problems, that is considered to be, okay, this is likely secondary. So if they are more than 50 and have a significant smoking history, and they have evidence of underlying lung disease, right? So that is a secondary pneumothorax. Hari. Now, the important message here is that you don't need to actively manage all primary pneumothorax. Primary pneumothorax you need not actively manage all the primary pneumothorax patients, right? If the size of the pneumothorax is less than 2 centimeters and the patient is not breathless, you can consider discharge and a follow-up in about 2 to 4 weeks. Right? So if the size is small, less than 2 centimeters, and the patient is stable, no symptoms, you can consider discharge and follow up in about 2 to 4 weeks. Right? Now, how do you measure this size? that is shown in this picture, and that is B. මෙතන B කියලා තියෙන්නේ. You measure the size of the pneumothorax, lung edge එකට from the rib cage at the level of the hilum. Right, so that's the hilum. So you measure the distance between the collapsed lung edge and the chest wall at the hilum level. Right, and that is what we commonly do. In America, as usual, they measure it in a different way, and that is shown for your information as A. Right, so America but most other countries follow this B, where you measure it at the level of the hilum. Right. So to come back, if that measurement is less than 2 centimeters and the patient is stable, not breathless, discharge the patient and review in 2 weeks. Right? But if the patient is size is more and or the patient is breathless, you need to aspirate the pneumothorax with a 16 to 18 gauge cannula, which you might have seen being done in the wards. Right? So that is the management there. If the aspiration fails, then you have to go for a chest drain. And in surgery, we would have talked about this French gauge of the chest drain. 8 to 14 French gauge chest drain is recommended. Right? If the aspiration fails. Right. That is a primary pneumothorax. 2 centimeters is a magic number there which you have to remember. Now I told you that some patients have a probability of having a secondary pneumothorax. What are the factors that determine this probability? They are more than 50 and have a history of smoking, or they have some structural lung disease known or in the X-ray you can see something, right? ILD or COPD or something like that. So now you have a secondary pneumothorax on your hands, right? Now, in secondary pneumothorax, we don't discharge patients immediately, right? So if the pneumothorax is extremely small, right? Extremely small nang, say less than 1 centimeter vertebrae adu nang, right? You can admit and observe. Observe කරන්න පුළුවන් පැය 24ක් යනකම් 24-hour observation period. So it's a very small 1 centimeter වගේ pneumothorax එකක්. But if the pneumothorax is more than 2 centimeters or breathless, immediately IC tube. So aspirate කර කර ඉන්න නගලන්නේ නැහැ. එකපාරටම අරන් ගිහලා IC tube එකක් දාන්න ඕනේ. Right? So පොඩි වෙනසක් තියෙනවා. As you can see, there is a difference in the management with a primary and a secondary. In secondary, again, this is based on a lot of evidence, right? නිකන් ඔහේ නිකන් හිතුමතේට කියන කාරණා නෙවෙයි මේවා. So based on evidence, we know that if the thing is big, secondary pneumothorax is big, more than 2 centimeters, then you have to immediately put a drain in. If the size is intermediate, that is 1 to 2 centimeters, again, you can aspirate and see, right? If it works. If it doesn't, you have to put a tube in. So as you can see, there's a slight difference in the story between primary and secondary. Right. Okay. So this you need to be slightly familiar with because you can get a best response MCQ on one of these concepts. This is a primary pneumothorax, less than 2 centimeters, patient is stable. What do you do next sort of story? Or there is a COPD patient who comes with a pneumothorax. What do you do next? So very easy to convert this algorithm into a best response MCQ. Hari. Right. So, Hari. So this is වැරදි එක ලොකු බොරුවක්. Hari. Right. And needle aspiration is not contraindicated. You can do it if the patient is going in this path. So just the patient is not breathless. The size is just 1 to 2 centimeters. You can aspirate with a needle. Hari. It's not contraindicated. You can do it, but only if the patient is not breathless and the size is 1 to 2 centimeters. Right? So this is the sort of algorithm that you need to be familiar with. And you can get a true, false or a best response MCQ. ලේසියෙන් හදන්න පුළුවන් best response MCQ එකක් මේක. Right. Any questions about this? Hari? Okay, good. Right, so those are all the pleural diseases that you need to know about. Now we are moving into pulmonary vascular disease, and we are talking about pulmonary embolism. Right. Okay. Now pulmonary embolism we talked about in detail during your acute medicine classes. I told you that pulmonary embolism, common presentation is with shortness of breath. Right. So these patients come to hospital with shortness of breath. Some may have a bit of a pleuritic chest pain, especially when the pulmonary embolus is distal, right? Distal pulmonary embolus. Well, you can get a bit of pleuritic chest pain. Massive pulmonary emboli can present with cardiac arrest or syncopal episodes. Right? Cardiac arrest and syncopal episodes in the pulwa. Right. Okay. I'm not going to go through this. This is just for your reference. Right. Now, how do we diagnose a pulmonary embolism? මොකද්ද මෙතන diagnosis කතන්දරය කියලා අපි බලමු. Now, remember that if your patient is unstable, if your pulmonary embolism patient, suspected patient is unstable, සමහර වෙලාවට without any damn investigation, we start treating them. Because you can't waste time. You treat them sometimes on a clinical suspicion. Right. But in patients who are stable, we have several scoring systems that assess the pre-test probability. So scoring systems අපි ගාන තියෙනවා to assess the pre-test probability. Again, what is the likelihood? So we have a clinical probability and there are tests and scores to assess, give a mark to that probability, right? Give a mark to that probability. You should know there are two such scores. මෙයා කටපාඩමින් දැනගන්න ඕනේ. Well score is one. And the other one is something called the revised Geneva score or revised Geneva clinical prediction rule. Revised Geneva and Wells. They are very similar. I have given these here, but you don't need to know in detail about these things. You don't have to know it by heart. So patients who are unstable, sometimes we just treat them without any investigations. But patients who are stable, we would like to do a pre-test probability assessment with one of these scoring systems. Right. And if you have a high pre-test probability, then you go for a diagnostic test like a CTPA. Right. So if there is a high clinical probability, high pre-test probability, then you go for a CT pulmonary angiogram, which is the recommended investigation for confirmation. Right? CT pulmonary angiogram is the recommended investigation that we use. Now, sometimes in young patients, especially females, young females of reproductive age or pregnant patients, we can use the ventilation perfusion scan. Right? Okay, ventilation perfusion කිව්වට ගොඩක් වෙලාවට it's only the perfusion that we do. Even though we call it a ventilation perfusion scan, it is usually only the perfusion that is done. Perfusion එක තමයි කරන්නේ. Right. So that is because the radiation exposure in a VQ scan or a Q scan is much less than a CT scan. Radiation exposure ගොඩාක් අඩු. So females who are pregnant, childbearing age females, we can consider doing a perfusion scan. But I told you during your appointment that in order to interpret a perfusion scan, they should have a normal chest X-ray. right? If they have some structural problem in the chest X-ray, the perfusion might be abnormal in that area, right? කොහේ හරි තඩි මොකක් හරි ප්‍රශ්නයක් තියෙනවා නම් the perfusion might be abnormal in that area because of that problem, that structural problem. So you can't say whether it's a PE or not, right? So an important prerequisite, the English word we use there is called a prerequisite, is that they have a normal chest X-ray. Hari? Right. So patients who have a high clinical probability, high pretest probability, a CTPA is the gold standard test. But you may also use a ventilation perfusion or perfusion scan in people who are worried about giving a lot of radiation too. Right. If there is low probability, right, as a rule out test, we use the D dimer. And again, in your appointments, I told you about this. D dimer, right, has a good negative predictive value. Right, has a good negative predictive value. In other words, if the D dimer is negative, you can confidently exclude a pulmonary embolus. Right? D dimer is negative now, you can very confidently exclude a pulmonary embolus. Right? An important thing about the D dimer is that if it's positive, it doesn't diagnose it. ඒක මතක තියාගන්න. Positive වුණා කියලා diagnose කරන්න බෑ. You still have to do a CTPA or a Q scan. Because remember, D dimer can be elevated in a lot of other conditions. D dimer එක වැඩි වෙන්න පුළුවන් තව ගොඩාක් හේතු තියෙනවා. MI වල D dimer එක වැඩි වෙනවා, right? Sepsis වල D dimer එක වැඩි වෙනවා. So there are lots of reasons that the D dimer can go up. But it has an excellent negative predictive value. So you can say without a problem, if the D dimer is negative, then no problem. You can exclude a pulmonary embolus. Hari. So this is how you diagnose a PE. So going back to this, positive D dimer confirms the diagnosis කියන එක වැරදි නේද? ඒක වැරදි. Well score කතන්දරේ හරි. Well score or revised Geneva prediction test එකෙන්. Right. Now, even though we say the gold standard of diagnosis is a CTPA, there are certain other investigations that might be important. Right. For example, I've shown you this ECG before during your appointment, the classical S1Q3 T3 pattern. Right. So that's S1, Q3 and T3. Okay. S1, Q3, T3. But remember the commonest, if somebody asks an MCQ, what is the commonest ECG abnormality? That is sinus tachycardia. The commonest ECG abnormality is sinus tachycardia. Right? Commonest is sinus tachycardia. But this is a rare ECG change that we sometimes see. S1, Q3, T3 pattern. Also, there are some interesting chest X-ray signs which are illustrated in this picture, right? Some chest X-ray changes, not very important for you to know, right? Right? Hampton's hump, right, is sort of a, it's due to actually this, that is not a good picture of it. හරි මෙන්න මේ වගේ Hampton's hump කියලා එකක් එනවා when there is sort of an area of pulmonary infarct. හරි? ඔව් වගේ. So there are various chest X-ray signs. Don't worry about them. Nobody is going to ask you now about these. Right. So there are some other investigations that might be useful. So ECG commonly shows S1Q3 T3 pattern කියන එක බොරු කතාවක්. ඒක වැරදි. That's wrong. Right. Now the last statement there focuses on management. The මෙතන මේ best response MCQ එකකුත් තියෙනවා. ඒකත් ඔයගොල්ලෝ උත්තර දෙන්න පුළුවන් දැන්. Right? So I'm not going to go into that. And this is a large PE on a CTPA. Hari. Now, this is the current recommendation for managing a PE, right? And the guideline is 2019 European Society of Cardiology, and that is the sort of up-to-date standard guideline that we follow. Now, right at the start, if you have a patient with acute PE who is unstable, right, the management is slightly different. Okay, so let's go through this step by step. Patient with acute PE, we will anticoagulate, right? We will anticoagulate. That is the standard of care. But an anticoagulation in Sri Lanka, we use enoxaparin or intravenous heparin, whatever you like. Right? There is no difference between the two, right? So whatever you like, you give. If the patient is hemodynamically unstable, if the patient is hemodynamically unstable, they need immediate reperfusion therapy and ICU for hemodynamic support. They need immediate reperfusion. Now, reperfusion we often do with thrombolysis, right? And you can use streptokinase or altiplase for thrombolysis, right? So, if they are hemodynamically unstable, you need to give them immediate reperfusion, right, with thrombolysis. Some people do various other interventional procedures as well to take the clot out and so on, but they are not commonly practiced. Tisura.
So we give thrombolysis after this anticoagulation.
Yes, everybody gets anticoagulation, Tisura, right? Everybody gets anticoagulation. Patients who are hemodynamically unstable additionally will get thrombolysis on top of that.
Okay,
Yeah?
sir. Thank you.
Right.
Sir, can you please repeat the choices that we use to thrombolize?
Thrombolize, altiplase or streptokinase. Right? Okay. Now, if the patient is hemodynamically stable, then it's a little tricky. Right? Little tricky. When they are hemodynamically stable, there are two things that you need to check. Right? One is, do they have signs of severe PE, severity, or a serious comorbidity? So, do they have clinical signs of severe PE or serious comorbidity? For this assessment, we use two scores. We commonly use something called the PESI score, or there's another score called the Hestia score. PESI score this gives a nice idea about the severity, prognosis, and assesses the comorbidities in the patient. In your slides, I have given you a simplified version of the PESI score. Just have a look at that. Right, so this is the PESI score. Hestia score very similar. So you use the PESI score to look at if this PE is severe, right? What is the prognosis or mortality risk of this PE, right? Does the patient have significant comorbidity, right? That is one thing you need to check. Another thing you need to check is there evidence of right ventricular dysfunction? And you can see this on a bedside echocardiogram, or a radiologist can actually see this on the CTPA itself. Right? Radiologist can pain on CTPA the RV dysfunction. Right. Okay, so does the patient have high PESI score? And is there RV dysfunction? Are the two questions we ask ourselves, the patient is stable. If none of these problems are there, so PESI low, there is no RV dysfunction, then the patient is considered low risk. And what you do is just continue anticoagulation, and you can consider early discharge. Right? So if they are low risk, they don't have a bad PESI score, their PESI score is okay, and their right ventricles are working nicely, then you don't have to worry too much. You can just consider early discharge and anticoagulation. Right? And anticoagulation is usually for 3 months up to 6 months and then needs to be reassessed in a clinic. But if either one or two are present, so either they have RV dysfunction or their PESI scores are high, they get classified into an intermediate risk group. Right? Intermediate risk group. Classify. There you need to observe them carefully, and some patients who have RV dysfunction, high troponin, they might actually need thrombolysis or reperfusion therapy. Take a පොඩ්ඩක් මතක තියාගන්න. So there is this intermediate group එකක් ඉන්නවා. They have a high PESI or a RV dysfunction. ඒගොල්ලෝ බොහෝම පරිස්සමින් you need to observe them. If they have high troponin, that then RV is under massive strain, right? That the troponin has gone up as well. This group of patients might need reperfusion therapy, right? Might need reperfusion therapy, right? So that is something that you have to keep in mind, right? That intermediate group with a high troponin might need reperfusion therapy, right? So that is slightly important thing. If the patient is unstable, there is no doubt they need reperfusion therapy, no kata, no sinam. But intermediate group who have a high PESI, have a RV dysfunction, then you need, and additionally, if they have a high troponin, then you need to consider reperfusion. Right. Sachit is an unstable patient. So next step of, if you have an unstable patient, the next step is anticoagulation. The next step is anticoagulation on clinical suspicion, then is thrombolysis. Make algorithm එක පැහැදිලිව තියෙනවානේ. Acute P, you have to first anticoagulate whatever it is and then give the thrombolysis. Sorry, okay, අපි MI කරනකොටත් we anticoagulate and give thrombolysis නේ, remember? When you give tenecteplase වගේ දේවල්. Right. Sorry. Okay. So that is the management of pulmonary embolism. Right. Any questions? ප්‍රශ්නයක් තියෙනවා. කවුද ප්‍රශ්න?
Sir, one question.
This is
the NICE guideline has this other thing called the PERC, the rule out criteria. Where does that fit in?
ඒක අපි සාමාන්‍යයෙන්, that's a different sort of thing. PERC නේ, PRC නේ?
PERC, yeah. Pulmonary embolism rule out criteria.
ඒකත් is very something similar to these Wells and revised cinema. ඔය වගේ තව ගොඩාක් scores. There's another one called the year score. ඔය වගේ එක එක ලබ්වල් තියෙනවා. හරිද? So it depends on where you work. The Wells score revised cinemas are very commonly used throughout the world.
Sir. Sir, අපි දැන් inoxaparin and heparin දෙද්දි මේ අර අපි දැන් මොකක්ද thrombolysis නැතුව වෙන මොකක් හරි mechanical thrombectomy එක කියන්නේ මොකක් හරි එහෙම එකට යනවා නම් inoxaparin දෙන එකේ ප්‍රශ්නයක් තියෙනවා සර්. ඒ කියන්නේ heparin
ඒක සාමාන්‍යයෙන් අර ඒක ප්‍රොසීඩ් එක කරන්න කලින් ඩෝස් එක දෙන්නේ නැහැ. එච්චරයි. But remember, procedures are very rarely done for PEs, especially in Sri Lanka. මෙහෙත් බොහොම අමාරුවෙන් තමයි කරන්නේ. මේ ගොඩක් වෙලාට these are medically managed. Right. Taruka, heparin, warfarin. Yeah, so in PE, whenever you anticoagulate, you have to use heparin and warfarin together, and then once the INR comes into the therapeutic range, you stop the heparin. That is what you do, that's when you continue the warfarin for 3 months and up to 6 months sometimes, depending on the cause. Right. Okay. Any other questions about P's, Lamai? මොනවා හරි ප්‍රශ්න තියෙනවද P ගැන? අද ගොඩක් අය connections අවුල්ද මේ කට්ටිය disconnect වෙනවා reconnect වෙනවා? Right. Okay. Chamatkar spondylometry algorithm is cannula aspirate, same as needle, possibly yes. Yeah. So yeah, එක විදිහට කරන ඕක, yeah, I think you can use that as the same thing. Right. හරි. Now මේ question number 6 එක නම් ඇත්තටම I don't think you'll be asked about this, right? Pulmonary hypertension is a very difficult topic. Very, very difficult topic. මෙතන මම ලොකු table එකක් දීලා තියෙනවා all the bloody causes of pulmonary hypertension. I think you have a lecture එකක පොඩි කෑල්ලක් on pulmonary hypertension. You don't have a full lecture on pulmonary hypertension. Somewhere in your modules there is a lecture කෑල්ල on pulmonary hypertension. But as you can see, there are lots of bloody causes of pulmonary hypertension, which can be classified. The main group is pulmonary arterial hypertension. Pulmonary arterial hypertension. But pulmonary hypertension can also occur due to left heart disease, lung disease. You can get pulmonary hypertension. Right. So pulmonary arterial hypertension is common in females. That is correct. All right. Now, in a patient with pulmonary hypertension, what are the clinical clues? Make up clinical short cases in pulmonary hypertension. These patients will have an elevated jugular venous pressure. So if you look at the JVP, that will be elevated. And then they will have a loud, palpable second heart sound in the pulmonary area. That is very typical of pulmonary hypertension. And they might have a parasternal heave on the left sternal edge, which indicates right ventricular hypertrophy. So that is all due to pulmonary hypertension. ECG can show right bundle branch block, can show sort of ST or T wave changes in the pulmonary, in the right ventricular leads. Sorry, put in. Okay. Right. Elevated BNP is diagnostic that doesn't, yes, the BNP goes up in pulmonary hypertension, but it's not diagnostic of pulmonary hypertension. In order to diagnose pulmonary hypertension, you have to do something called a right heart cardiac catheterization and directly measure the pulmonary pressure. Pediatrics, you might have seen neither in LRH, they do this right heart cardiac catheterization quite a lot. So to diagnose pulmonary hypertension, that is the gold standard test, a right heart cardiac catheterization. Right? But that's obviously an invasive thing. You can estimate the pulmonary pressure using an echocardiogram. Right? Echocardiogram, you can see or estimate the pulmonary pressure. But the gold standard is this right heart cardiac catheterization. Right heart cardiac catheterization you do something called a vasodilator response. එක vasodilator එකක් දාලා vasodilate වෙනවද කියලා බලන්න පුළුවන්. And that's quite important for treatment, right? Patients who during their right heart cardiac cath have a vasodilator response can use things like calcium channel blockers for treatment. හැමෝම respond වෙන්නේ නැහැ. ඒකයි අමාරු කතන්දරේ. Everybody doesn't respond. Right. Typically on chest X-ray, what you see is very prominent pulmonary arteries in the hilum. But as you go towards the periphery, it will be more oligemic. So the typical appearance of pulmonary hypertension on chest X-ray is in the middle, they will have a very prominent pulmonary arteries. But as you go out, they will have oligemic lung fields. Right? This is called peripheral pruning. Prune karana gas kapane wateyata prune karanawa කියලා කියන්නේ. So this is called peripheral pruning, right? And that is something you see on the chest X-ray, peripheral pruning. So plethoric lung fields නෙමේ peripheral oligemia තමයි එන්නේ because the pulmonary hypertension එක මැද හොඳට පේනවා එළියට යනකොට කළුයි. So that is oligemia. Right. A range of drugs are used for managing pulmonary hypertension. as I told you, calcium channel blockers can be used if their vasodilatory response is intact. But otherwise, we use things like endothelin receptor antagonists, which are vasodilators, bosentan කියලා drug එකක් තියෙනවා, ඒවා පාවිච්චි කරනවා. Sildenafil, right? Sildenafil is also used. It's a phosphodiesterase inhibitor. Right. So those are some. It's very unlikely that you'll get a question on it, but yeah. Just ටිකක් for completion ඒක කිව්වා. Naveen is asking, tricuspid regurgitation itself can cause pulmonary hypertension, but TR දෙපැත්තටම, right? Chicken or egg වගේ යන්න පුළුවන්. Yes. Can work both ways. Because when there is pulmonary hypertension, the right heart dilates and gives rise to a tricuspid regurgitation. Right. Last two questions are based on lung cancer. And the first of the two, the first one is easy. So patient presents with cough and blood-stained sputum. What are the features that suggest a bronchial carcinoma? Make a ලේසිනේ බා. So exudative pleural effusion, හරි. Small muscle wasting of the hand, remember, Horner's syndrome, Horner's syndrome. This is another very famous one, SVC obstruction, right, where they have a very plethoric swollen face with neck vein distension, dilatation of the neck veins, and also chest vein dilatation. And you know about Horner's syndrome, small muscle wasting, which is Pancoast tumor. Hypertrophic pulmonary osteoarthropathy is a state of very severe clubbing, which occurs in squamous cell cancer of the lung, right? HPOA. There is very severe clubbing, also wrist joint involvement, right? So there is severe clubbing with wrist joint involvement. That is HPOA, hypertrophic pulmonary osteoarthropathy, HPOA. Finally, you know that bronchial cancer is associated with a load of paraneoplastic syndromes, right? And one of them can be this ectopic ACTH related Cushing syndrome, right? When we do Cushing's in endocrinology, we will talk about this in a little bit more detail. But HPOA is an important, proximal myopathy can occur due to this paraneoplastic ACTH secreting tumors, right? So that is another possibility. So this is a picture of HPOA with the very gross clubbing, and also there is wrist involvement as well. Patient have wrist joint pain. And this is a picture of Pancoast tumor. This is the apical lung tumor with Horner's syndrome and small muscle wasting. The reason is, when you have small muscle wasting, is that it involves the lower trunk of the brachial plexus, which carries the T1 root. Clubbing can occur in pulmonary hypertension because of severe pulmonary hypertension can cause hypoxia, right? So that is the reason. Right. Now there are various sort of histopathological types of lung cancer. You have the squamous. Main two types are the squamous and adenocarcinoma. Right? So squamous cell carcinoma is you see a lot of it in male smokers. Right? So squamous cell carcinoma of the lung is quite common in male smokers. That is the group, the epidemiological risk group. Adenocarcinoma is common in females. That is wrong. There is another type of lung cancer, which is the small cell lung cancer, which is associated with paraneoplastic syndromes. Right? There are whole lots of paraneoplastic syndromes, especially endocrine, the Cushing's that we were talking about. Endocrine paraneoplastic syndromes. Right. Sorry. So that is right. Now, I just showed you a picture of a patient with Horner's syndrome due to apical lung cancer, which is part of this Pancoast syndrome that we were talking about, the ptosis, the small muscle wasting of the hands. treatment modalities are extremely complicated, but squamous cell carcinoma is treated with radiotherapy, right? It responds very well to radiotherapy. Adenocarcinoma responds to chemotherapy usually. Right. So these are not very common MCQs, but I've just given you one or two just to complete for completion's sake. Hari. Okay. Nipun Hajana Naveen question. How does so TR, because of the right side, the volume overload on the right heart pressures can go up with time, which can cause pulmonary hypertension. It can be reflected onto the pulmonary system, causing pulmonary hypertension. Right. Right. This one is a bloody easy one, no? Make a hyperventilation. Yes. And there is a SCQ about a pleural effusion and related investigations. Hari. Okay. Right. So that is all respiratory done. So you've done cardiology and respiratory medicine. All done. Any questions? Saturation drop on walking in whom, Ashwa? Sorry. Go. Sorry. Does not fall. Sorry, I have made a typo. Right. So the saturation does not fall. Sorry about that.
Sir, what is so what is invasive pneumococcal disease?
Invasive pneumococcal disease.
Yes, sir. There was a MCQ saying pneumonia is an invasive disease.
What does that mean? That has no meaning.
Right.
කොතනද past history of TB එකක් තියෙන්නේ? කොතනද? I'm sorry, have I not put SBR ද SCQ එකේ? කොහෙද මේකක් තියෙන්නේ? Seventh question. මේකද? So past history of TB has nothing. No. Past history of TB doesn't indicate the risk of a bronchial carcinoma. Right?
Hello, sir.
Yes.
Sir, isn't there a risk of adenocarcinoma on scars?
Apo, that's a very rare thing.
Yeah, thing, no?
Yeah.
Okay.
Yes.
That's false, no, sir?
False. Yes.
Thank you, sir.
Right. Any other question? Samat. ඊගාවට මොකද්ද කරන්න ඕනේ ඔයගොල්ලන්ට? මොන සෙක්ෂන් එකද කරන්න ඕනේ? Oh, you don't mind, eh?
Yes, sir. We won't mind. Yeah.
Hari.
Anything.
මම අද පොඩ හිතලා බලලා දාන්නම් ප්‍රශ්න ටික අපි හෙට නොකරෙමු. next week Tuesday වගේ පුළුවන්ද කරන්න?
පුළුවන් sir.
ඔව් ටික වෙලා දෙන්න එපා ඒක කරන්න. මේ next week Tuesday වගේ කරමු මම වෙලාව කියන්න සඳට. I'll put the questions on the whatever this classroom thing. Right?
Okay, sir.
Hari.
Sir?
Oh.
Sir, clubbing, sir, it's seen in all lung cancers, but the severe form is only on squamous cell carcinoma?
Clubbing squamous එකේ තමයි එන්නේ. It's not seen in all lung cancer. For example, things like small cell well, you might not get clubbing. Yeah? But definitely in squamous, you will get clubbing. Yeah?
Okay.
Yeah. ඊපස්සේ තව ප්‍රශ්නයක් තියෙනවා SLE can cause hemorrhagic effusions. Yes. Primary pneumothorax happens is, so if they have a strong history of smoking, it is very likely that it's a secondary pneumothorax. Hariද? Because you will have some sort of emphysema when there is a strong, especially when they are more than 50 years of age. Right? That's why that algorithm, 50 years of age plus smoking, go into secondary. But if they have been smoking for 1 or 2 days and get a pneumothorax, that is a different story. No? So it's probably primary. So that's why the age and the history of smoking needs to be taken into account together.